All right, good afternoon, everyone. Um, my name is Dr. Shubham Bakshi. I am the moderator for this talk today. This is part of our Together in Care initiative by the American Academy of Pediatrics. Our goal is to empower the neonatal teams in palliative care. Today's session is going to be It's Not a Gift, It's a Skill. And this is going to review some key components of becoming an expert communicator. This is going to be the talk is going to be by Dr. Natalia Henner. She is currently at Lurie Children's Hospital. She completed her neonatology fellowship at my alma mater, Tufts Medical Center, in 2012, and she did the Pediatric Hospice and Palliative Care Medicine Fellowship at Northwestern Memorial Hospital in 2015. She currently practices neonatology and pediatric palliative care at Lurie Children's Hospital in Chicago. She is a co-director of a perinatal palliative care program and serves as an interim division head of pediatric palliative care. Her academic focus is on improving care for families of infants with life-limiting conditions with a focus on systems to improve complex communication. Her passions are counseling at the borders of gestational viability, integration of palliative care in infants with severe BPD, and multidisciplinary care for infants with trisomy 13 and 18. She co-directs a communication simulation course in neonatology fellowship and is a part of several national working groups in this sphere. This talk is funded and supported by the AAP section on neonatal perinatal medicine, and there are CME and MOC Part 2 credits available by the Medical College of Wisconsin and Children's Wisconsin. The QR code for registration is here. Can we have the next slide? Just some shout out for some of the upcoming webinars after this. The next one is going to be on April 8th. There is a time change. This is going to be at 3 p.m. Eastern. And the topic for that one is going to be palliative care in the NICU and beyond. How does ethics fit into this big puzzle of palliative care? The registration links and the QR code are available. Also, Together in Care initiative and the TCAN advocacy campaign QR code websites are also available here.
All right. Thank you so much for having me. We'll start with this quote from the experts, as I will let you read as everyone is just kind of getting settled. I think most of us think that good communication is a gift, and some people are just naturally very, very skilled at it, while others are not. But everything can be learned if you treat it as a learnable skill. Perhaps checklists and some of these sort of like memorized phrases that we'll walk through seem less true, less sort of honest somehow, but I promise you that they work, and we'll talk about them today. When I think of primary palliative care skills, they really fall in three different sort of sections. Communication and complex decision-making, which is mostly of what we'll be talking about today, but of course also symptom management and care of the dying patient. I truly believe that every neonatologist can and should have excellent primary palliative care skills. This is really the goal of this talk. And the question of when are subspecialty skills needed are fairly complex. I think often the more subspecialty palliative care skills are needed when you think about continuity of care, whether it's within the NICU or beyond. Any just higher level of challenges in any of the three domains above. And these are also fairly kind of like unit and culture dependent on when to call a subspecialty palliative care consult. So what are some of the communication skills parents and experts think that we should learn? Well, as you see from this list from one of the studies, it's pretty much all of them, from discussing the complex medical diagnosis to running family meetings, discussing code status, discussing stopping medical therapies and such. It's a long and daunting list for some. How do we learn these skills? This is one study that's assessing program directors and trainees' views on having palliative care skills as part of the teaching curriculum, with only 30% of trainees sharing that they are being taught palliative care skills and feeling mostly uncomfortable with key aspects of palliative care delivery. In this other study, looking at how trainees get skills in periviability counseling, for example, the vast majority of trainees shared that they learned these skills by watching the senior faculty. However, when asked who typically does this type of NICU counseling, only 29% of trainees shared that they counseled together with a NICU attending, with the majority saying that they either counsel by themselves or that the faculty follows them after that initial consult, meaning there's a gap in how we think we learn these skills and how we actually learn them. So what are some of the communication challenges that are very specific to our specialty? These are some of the possible ones. There's just an inherent prognostic uncertainty in our specialty, perhaps much more so than in others, as we're often dealing with the imperfect fetal diagnostics, just many variables in the perinatal care course, and unclear disease pathways. There's also data that I'll share later on varied views parents and clinicians have on the future. Our patients are in the unit for a long time, with maybe limited chances for trainees to appreciate what long-term counseling might look like over many months, potentially. Communication with young parents may be difficult for a few reasons stated here. And finally, there are just many, kind of like inherent complexities to our patients in our field that impact how we think about all these issues and how we feel about them. For the purposes of this talk, we will only touch on these two challenges and use them as use them as a basis for our discussion. So let's dive into this prognostic uncertainty as a communication anchor when it comes to possibly life-limiting conditions. We'll discuss why it's hard and what we can do about it. So imagine that you're in a fetal consult and in front of you is a 37-year-old woman. It's her second pregnancy. She already has one healthy child at home. Trisomy 18 has been confirmed at 22 weeks gestation. She's currently at about 26 weeks gestation. This baby is very small, has a large VSD, cleft lip and palate, and a horseshoe single kidney. Is there a chance of all of these outcomes? The answer is yes, and probably hundreds of other combinations and outcomes, depending on what the family wants, depending on what the team is being able to offer, and so on and so forth. All of these things may actually happen. When we are faced with such dramatic range of uncertainty, we may have some pretty significant feelings about it. We start talking about suffering, unreasonable hopes, all these other things listed on the slide. We don't have time to dive into the data behind each of these, but I just want to take really a few minutes to kind of create a shared kind of like thought process behind these. So when we say suffering, do we mean physical or some other kind? Is it babies, families, or ours? When we say these hopes are not reasonable, I will just ask according to whom and whose hopes. When we say these babies facing months to possibly years in the hospital, I'd say that's probably true, but it's similar to kids with many other complex and chronic conditions. When we worry about cost of care and we use that language when we talk to one another or to even families sometimes, I'd say that's probably true. It's quite expensive. It's also quite rare. There's also now no framework of limiting care for other high-intensity NICU condition with uncertain outcomes just based on cost alone. When we say this care might be medically futile, you will hear from many others, I'm sure, as part of this series, that this is a flawed ethical construct. When we worry, again, either just to us or even to the family about family stress and negative effects on siblings, I'd say that's something we should talk about, but there is a lot of seminal papers, including these two, that actually say maybe we shouldn't worry about it as much, that families can experience a lot of joy, that siblings are quite healthy, and so on and so forth. When we talk about poor neurodevelopmental outcomes for that particular baby and use that as a communication anchor, I'd say that's probably true, again, depending on how you define poor, but most babies who survive with trisomy 18, even for years, of which there's now many, I assure you, the developmental potential is not higher than 12 to 15 months. That is true. But there's a varied importance of this to some families, to many families, in fact, especially as we continue to say that most of these kids will die before 1 year of age. Clinicians' distress is important. You can also change it and turn it into something else. And the fact that this is too new, I'd say yes, but like everything in the NICU at some point. Whenever complicated sort of bubbles pop up like this, I find these questions good to ask to promote a better sort of better conversation between families and between teams, because I really believe strongly that good communication within teams is a foundation for good communication with families. I ask trainees, is this the sickest patient in your unit? Why do you feel this way about them? What do you know about the outcomes beyond this unit's outcome? Who would be hurt if we have to try this baby survive? Why does the family want what they want? Am I influenced by how others around me feel? Are there different sources that influence how I feel, such as cost, length of stay consideration, and maybe, I guess like even something about the family? And to that, let's flip the script for just a brief moment. This was our patient in front of us. What if it was this patient? And what about this one? It is honest and important to acknowledge that there are many social and societal variables contribute to how we feel about a certain problem and how we talk about it. And these are just some of them listed on the slide. We also need to recognize that there is a balance in communication based on who parents are as people, with their kind of like innate sense of who they are. Before they became pregnant, they already had either a trust or mistrust of healthcare system, a sense of risk-taking and tolerance of all these sort of question marks about the future, their faith, their memories, their coping, and views of all other kinds, in all of which frame themselves as parent and patient. And of course, the same is true for us. Many things contribute to what we bring to this conversation, what we state as true facts, and these sort of quote unquote facts, which are maybe more reflective of how we think about the future. There's some interesting data in difference in prognostic views between clinicians and parents, and I urge you to seek out this type of literature as you're thinking about your own prognostic conversations. This is just one study that's assessing parental and physicians' views on prognosis for babies with various CNS conditions, significant bleeds, strokes, shunts, and so forth. You can see that the discordance about the future occurred in 70% of the parent-physician dyads. Of the parent-to-physician dyads with these differences, the majority contained a difference in what parents actually think would happen instead of what they sort of sense would happen, the belief. When you look at the figures, the mothers are represented in black bars and physicians are in gray. When asked questions about their baby's abilities to take steps and have speech by age 2, you'll see a sort of a visual difference, just a different type of slope almost, with majority of mothers saying possibly yes to definitely yes, and with most physicians having a much more kind of like negative view on the future. There's a lot more to say about these data, whether moms are different from dads, and why parents have such different views from clinicians. But I really just wanted to give you a taste of this topic so you can read about it more and think about it more on your own. So let's get more kind of granular into the communication partnerships for the clinicians. So first, I think we should strive for the practice cohesion as we communicate our plans and possible limits. We can do this by learning the local and the national care trends for each complex condition. In this case, for example, for trisomy 13 and 18 and complex cardiac repair, and to acknowledge our own institution's place on this spectrum. Are you in a place that is still deciding whether to offer cardiac surgery and chronic mechanical ventilation? Are you in a place that is kind of like stratifying the risk and the clinical decisions based on that risk? Or are you at a point of considering things like ECMO? Next, these are the 3 kind of like meta points that I would talk about. We definitely need to describe what this diagnosis means, both short-term and long-term. I would encourage you to talk about how babies live and not just how they die, and to stratify risk and talk about that. This is a good example of delineating a disease severity prenatally and ways to possibly stratify risk, which can be used as an anchor when discussing the prognosis, possible therapies, sort of, again, some views on the future and some choices that parents are facing. There's also some postnatal findings that may heighten that risk and can be used to guide the family. But I think most of us would agree that a baby with a reduced risk findings is very different than a baby with higher risk findings, and that their prognosis should not be talked about in the same way, even though they have the same type of general problem, trisomy 18. I would also consider that the reasons parents continue to speak and write about babies who surpass their expectations is partly because we lower them intentionally. But why do we do this? This is a lovely essay on pessimism in our field. It's possible that we conflate truth with pessimism and are just too brutal when speaking about the truth. It's also known, as I've showed you before, that we're just much more, grim about the future outcomes, and that parents tend to be much more positive about the future. And lastly, it's possible that we feel the weight of these decisions and worry that parents will have a sense of a regret, even though multiple studies show that they rarely do. I often suggest to trainees who might be new to these spaces that if you're setting up for a fight, you will get one. As demonstrated by this very, very eloquent quote from an article describing counseling and CV surgery approaches for babies with trisomies, when parents are being presented with all the things that you won't do, they may start to fight for things that are unfair without the larger context first. Nothing should be black and white. It might be easier to use these sort of like shorthands to paint a picture, but it's probably best to not do so. Some highly technological and surgical things can also be helpful, palliative even, if you consider symptom management in that category especially. For example, chronic mechanical ventilation and VSD repair can help with the sense of dyspnea, can improve the sleep and state regulation, can improve growth, and help kind of meet whatever developmental goals this baby might be able to meet. Instead, it might be best to acknowledge that surviving babies would likely have chronic critical illness. Chronic critical illness is defined as you see here on the slide. I would argue that currently at Lurie NICU, about 80% of babies would fall into this definition. Chronic medical technology is very common and tends to be lifelong for kids with CCI. This matters because there are tremendous caregiver demands, both in terms of time spent on care, financial burdens, and psychological costs, as you see here. These challenges are also higher and worse for families who are already much more vulnerable or live in areas with fewer resources. And while significant attention should be paid to all of that, and we should do a really good job trying to prepare parents for what the future might hold, we can't only talk about the negatives of that future. We must also mention that despite the many, many challenges these kids might have, there are many ways to support a good quality of life, to make meaning, to have deep social and family connections, to be part of the community, and to take a lot of pride in this caregiving role. When discussing outcomes, I would also urge us to think about discussing outcomes as valued by families. This might be a pivot for some, but there's an emerging body of work that focuses on parent-centered outcomes in peer viability counseling, BPD, and other conditions for which we as a medical community have previously kind of like decided what to measure without a lot of parental input. This lovely essay by Paige Church and colleagues gives us some of the suggestions on language to use when talking about some of these long-term differences in development and challenges, and offers a reframe in the words that we use. She and others have been suggesting that instead of using the scales and the buckets to describe how challenging life might be for each child, we should really talk about the functional outcomes that would then impact this child and the rest of the family. At the end of the day, all parents want to be good parents when caring for their sick and vulnerable children. This seminal work from Chris Feudner highlights how parents define their good parenting attributes. What strikes me every time I look at this figure is that keeping a true true outlook is on the very bottom. And I wonder if that is maybe at the heart of the tension that we feel with some parents. We want this bar to be on the very, very top. And it's just not. Yes, some things are really scary and unpredictable, like they were for our patients who were born at less than 34 weeks with full trisomy 18, was mechanically ventilated his entire life, has had multiple code events, underwent 2 cardiac surgery and a liver surgery. He spent over a year in the hospital. He's now 2, but his pathway forward is still not really guaranteed. What I know is that he has more good days now than bad ones that he had in the hospital. Would it have been better if he died shortly after birth? And better for whom? Who should ask that question and who should answer it? I strongly believe that it should be his parents with us as guide and not the other way around. So this is a little bit more an additional and helpful and not helpful language to use when we think about these broader constructs. Trial of therapy is potentially a very sort of helpful construct to employ. It means determining progress or lack thereof within a set time frame, during which all curative therapies are provided, and then we rethink them. Trial of therapy can be days to months. I would want to acknowledge that we typically want a shorter time frame than parents. We want this trial to happen pretty quickly, and I'd say some parents maybe need even months to years. It sets up a framework for possible future choices and healthcare pathways, decisions, such as extubation trials, technology use, overall care direction. It truly should support hope while being a realist about some of the worries. It's sort of a balancing act. The important thing to talk about if you're going to employ this phrasing or this concept is who decides the time frame? Is it you? Is it the parent? Is it together? Who defines progress and how? And what happens if the trial is not successful? So it's lovely to use that word, but I think there's a lot of other thought that needs to go into that. For example, I would say, I suggest we give it 2 to 3 weeks to see if he can start to move more, spend more time awake, and maybe swallow better. I really hope these things happen. If they do, then it would be encouraging that other progress might be possible. But if they don't, it might mean that ongoing progress is unlikely, and we should regroup to discuss how much technology to use to continue supporting these basic functions, or whether your views on those technologies change. Suffering is a complicated word. Personally, I hate it. Just on a personal note, I would only use this language if the family is using it. I would never use it first. But if a caregiver, if it's your nursing colleague, maybe it's your fellow, maybe it's your attending, maybe it's your resident, maybe it's a family that's using this language, then you really have to dive deep into it and ask specific questions. What do you mean by suffering? What specifically indicates to you that the patient is suffering? What concerns do you have about their experience? If concerns are about physical symptoms and pain, dive right in. Be my guest, fix it all. But usually it's something else, and it's important to get at the core of that. And if there's true evidence of either parent or caregiver suffering, we have to spend a lot of time there. Physical stuff is usually fairly simple to fix. I'm not saying always, but that's not typically what, I guess, like what is at the core of this language. I would say that we as clinicians often worry about non-physical suffering, this other broader sense of suffering, and we think that parents should worry about it too. We almost want them to worry about it too. So if the family is using that word, a lot of us want to jump on it right away and be like, aha, this is the moment. We're talking about the future, major decisions, maybe not putting in a trach in. But I would encourage you to not assume that that's what parents mean and just ask some clarifying questions and explore instead. These are some of the examples of maybe how to go about it. I've heard you use the word suffering earlier. Can you please describe what you mean by that? Other things to consider is to say, it must be hard to even consider that your baby is suffering. Thank you for being open with us about this. Tell me what worries you. If it's physical, say, I heard you say you're worried about his physical experience of this illness. Is there anything else that's on your mind? Again, always ask more open-ended questions than assume that that word means the same thing. Quality of life is another one of those phrases or turns of phrase that's being thrown around constantly when you talk about the palliative care skill set. It's like with suffering. I almost never say it first unless I hear it from other people first. And the reason for that is I think there is such a subjectivity of this phrase. I think if you use it first to a parent, some will have a very positive response to that and will feel like the door is opened. to things that are hard to say. And thank God you're starting this conversation. But I would say the majority of people would actually know that you have a negative bias about that and might feel a threat as you're using this language. We have to appreciate how flawed most of the quality of life assessment tools are in our field and in others. And there's numerous data that's showing how clinicians and parents are not the same when we talk about current quality of life and future quality of life. Quality of life is not linear to technological dependence or comorbidities. We, I think, make a lot of assumptions that it is, that kids with more technology have poor quality of life. That is unlikely to be true. And it's also important to understand that cognitive outcomes are not a proxy for quality of life. We often kind of lump those together, but that is not true for a lot of parents that we take care of. So again, just be careful what you mean by that. Ways to maybe use that phrasing in a more sensitive way, if it comes from a family, to say, I've heard you use the term quality of life. What comes to mind when you think about what is acceptable and not acceptable quality of life? What is currently making you worried about her future quality of life? And you can even validate that and say, we worry about that too. Are there people in your life who have different views on quality of life? Why are they different? Tell me more. The language of miracles, that is a hard one. I feel like our natural instinct is to either squirm away from it, cringe, pivot, avoid, but I encourage you to do the opposite. Don't dismiss it, explore it. Just recognize the anguish of that particular word if it's used by a family. Some potential suggestions is, it must be so difficult to be at a point when only a miracle would save him. What would a miracle look like? I really hope for a miracle too. He needs one. How should we prepare in case that it doesn't happen? Can you tell me of other times in your life when a miracle happened? If you actually dive towards the miracle language, it will open so many doors. But again, because we're not trained to do it, we tend to squirm away from it or just think of it as a negative turn in the conversation. So these are some concrete sort of phrases to practice to add to your communication toolbox. And I promise these are just, like these are not just like my ideas, but suggestions that have been validated in different SIMS, curricula and some checklists. If some of these mnemonics or models help you remember how to do it, please do that. I personally like to map out a difficult conversation into sections, and I'll walk you through some of the ways to do that in a practical sense. For the preparation, I urge you first to gather your thoughts, even if it's only 1 minute. Just take a mental beat. Recognize this as a stressful situation. Nobody loves doing this. I do this for a living, and I don't love having these conversations every day. Come up with an outline. And the reason for that outline is I would ask you to pretend that you only have 10 minutes to do this. What are the key things that you need to convey at the end of this conversation? I'm not saying rush, right, like through it in 10 minutes, but it might be over sooner than you think because you need to say a really hard thing. So what is absolutely critical that the family walks away with and what is not? Pacing is a good foundation for setting the discussion. It's defined here, just a process of getting into the same space as the parents by matching the speed, mood, posture of parents during the discussion. This is easier said than done. I talk very fast, and so I have to slow myself down when talking to a family who's slowly speaking. And to a family that is heightened, it's sometimes nice to meet them at that heightened place, but then you realize that everybody's heightened, and you actually need to model how to bring that temperature down by speaking slower. Empathy. We can spend a day, 3 weeks, just talking about empathy because it's really at the core of all of these conversations, how to practice it, how to teach it, how to use it. We don't have time for that today, but it's in general just an ability to understand the family situation, perspective, and feelings, and to communicate that back to the family. It's especially useful when people are really, really angry. Naming emotions is the thing you can do over and over and over again. This is what the palliative care subspecialists do. They just recognize verbal and nonverbal cues and use that constantly. So you can just see things like, I can see this is surprising to you. People worry about naming the wrong emotion. I'd say don't worry about it. You might misspeak, you might misrecognize something, but it still moves the conversation forward and it allows the family to clarify. If they were mad instead of surprised or surprised instead of mad, it at least gives them a perch to say how they feel with some guidance from you. And using family's words back to them. This does feel like a bad dream. If you're delivering some really challenging information, I urge you to deliver it early and not do a long ramp up summarizing the day, summarizing the course. Most people know what you're kind of there for, so I would just urge you to get to it. Consider a warning shot. You see some of these here on the slide. You have to say information in plain words. You may have to practice them ahead of time. We're always taught to not use any medical jargon. I would strongly agree with that. But I think you still have to say the word of the condition, right? HIE, trisomy, congenital heart defect, because it gives people a sense of agency of what it is. They can later go to online resources. They can say it to their families who might be in medicine. If you don't ever say the actual words, that's also tricky. So it's a delicate balance of stating the diagnosis and the problem in medical terminology, but then spending a lot of time actually talking through what it means. Once you've given difficult news, I urge you to pause. And that means if you have to internally count to 3, do it. It actually usually takes longer than 3 seconds, but 3 seconds is what's been shown to make a little bit of an impact. But try to sit in silence longer if the family looks like they're still trying to collect themselves. You will almost always get a nonverbal or verbal cue for permission to continue. If people are looking on their lap, not making eye contact, just looking visibly shocked, count for a little bit longer. They will always look up and ask you a question, or they will just look up quietly. And then that is your cue. Avoid proceeding directly to next steps and outcomes unless the family is guiding you there. Again, just land a plane that is hard to land and then wait for the next kind of section in this conversation. If the news was coming, again, many people are bracing for certain things. They're often very much on the same page as us. Consider asking whether the family was expecting it. It allows for a conversation and not a lecture about this particular condition. It explores hopes. Ask some things like, I guess, just some things that you see here. Were you bracing for this? What was the hardest thing to hear from what I said so far? This is another time asked through every single section here is to practice empathy. I wish things were different. This must be challenging. I can see that you're shocked. Short sentences, very concise. There's going to be a lot of nonverbal cues peppered throughout all of these, whether it's a peer viability counseling, congenital differences counseling, disclosure of an MRI result. There's a ton of nonverbal cues that people give us. These are some listed here: looking away, spacing out, maybe grabbing a phone, starting to scroll, obviously crying. I would take it as a crumb and pause with every single one of them. If people are not looking at you, it's highly likely they're not able to hear you. So whatever you're talking about next, outcomes, prognosis, plans, it may not be actually going inside their head. Name a possible emotion associated with whatever cue you're seeing. If people look almost relieved or they look ready to engage, you can say, I can see that you were maybe, ready for this. But if they're completely spaced out, I guess you just have to wait. Avoid long stretches of talking without family's engagement. This ask, tell, asks is a nice, simple tool. Like, would it be okay to discuss what this could mean for her? The parents say yes. You briefly explain again in a concise way what it means, and then you ask again, could you share your thoughts on what you just heard? It allows for families to speak more. There might be hints about how much information the family is ready to receive at one time. Some people just cannot continue after you said a really hard thing. So you can offer them a little bit of a reprieve. It's okay. Do you want us to take a small break or should we continue? You can say, we've talked a lot. What would be helpful to talk about next? Give people a sense of an agency of where they want to go. They might still spend more time trying to clarify this diagnosis, or they're actually ready to move on. But it's probably best to ask before you decide where to go to next. Parents always want to parent, especially at a time of a crisis. And you may want to take a pause to allow for the expressions of that. And what I mean is, like, if you're talking in a family room and there's a baby right there, and you say something really hard, You may see a parent go to the bedside, hold their kid's hand, or just lean into their baby's body. And that is all they can do right now. Do not keep talking. Let people be with their kids. This is probably the hardest thing they've heard, in ever. And so allowing for a little bit of that parenting pause to feel a connection to their baby will really help in the future. There's often feelings of guilt. You guys know that. Spend some time processing that. If you get any hints from that from the family, be prepared from questions from online sources by not just dismissing them and not having an eye roll about, like whatever it is parents are suggesting, but you can just say, I'm not familiar with this therapy. Can you share a bit more about what it is and where you read about it? It makes people feel heard. It allows them to talk more than you do. Uncertainty is the worst. You know this, I know this. So just say it. Say that you know it's awful. You can say, I know it's hard to continue hearing. We don't yet know. How many times can one hear that? It's like you've lost all control. This is the hardest part. Let's talk about where there might be some ongoing uncertainty and what we know for sure at this time. I often say uncertainty is hard. It's the hardest part of the NICU journey for parents. How do you deal with uncertainty in general? Were there other instances in your life where things were unclear, and how did you get through them? You want to get at eventually, again, maybe this is not one conversation, maybe this is 5, but you want to talk about future directions. And you can say, this is what I think our next week's goals are, our next month's goals are. Make it more concrete. Don't just talk about a broad general future unless the family is guiding you there. There's always hope, you know this, or I guess I hope you know this. So conversations about hope are really important, even in the setting of really bad news. You can just ask, what continues to bring you hope, if anything? It's often not a beginning of a conversation question, but maybe it's towards the end. You need to summarize things concisely, and you have to make it short. You can validate that this was a ton and that you will come back. Again, today was a lot. Can we just come back to this tomorrow? The lingering is something we always do because we want to make this nice in the end. So I'm often in meetings where you said a really hard thing as a group, and then everybody feels like we're done. And now you're asking questions about the kids, about the drive home. Again, there's this kind of lingering in the room because you want to make a human connection. But if you've been making a human connection this entire time, you don't need the lingering. Most people actually just want you to go. And you can ask, like, is this a good time for us to end? I see this was a lot. Would you like to stay in this room with a chaplain, with a social worker, or do you want to go back to the bedside? Is this a good time to talk about decisions after you've just disclosed challenging news? Sometimes the parents are guiding you there, but you have to read the room. It's tough to talk about decisions right after you've disclosed tough news. You can wait for, so what does this all mean? And again, you can give parents agency in whether they want to talk about that. Some people have already thought about decisions, so ask them instead of telling them. Suggest there might be a conversation about decisions if the parents are not using that language, and name the actual decision. For example, at some point, we'll have to decide together whether a shunt is a next step. We'll guide you through all the options. Some parents choose this and other parents choose that. This is kind of my very oversimplified, but really palliative care questions 101. You can use them when you're stuck. You can use them in the beginning. You can use them in the end. You can throw them in anywhere. They will usually get you to a conversation when parents start talking and explaining who they are and what they feel. Have you read anything about this condition? And not only that, but what stories do you gravitate towards and why? I'm always surprised when I ask that, especially in, in the trisomy community. There are some parents who say, yes, I'm online a ton. I see all these pictures of kids with tracheostomies who are 3, and I just cannot imagine my life like that. And I actually mostly read about babies who've died because I feel like I need to more kind of brace myself for that. And other parents say the exact opposite. Yes, I know that there are babies who die. I see those stories. They make me incredibly sad. However, I only want to read about kids who are alive. I want to learn about chronic mechanical ventilation. It helps you structure and consult in a way that it's actually meant to go. Most parents, and you all probably know this, have usually made a set of decisions before you ever came into the room, based again on who they are as people before. So try to understand who they are and why they made those decisions. I would always ask if you know anybody with a baby with this condition, whether it's 23 weeks gestation, severe BPD, trisomy, congenital differences. Ask about what they think about those experiences on behalf of those other parents. How do they perceive those outcomes? What do they feel about those outcomes? This in itself can be an hour that guides your entire consult. In the beginning, you can ask what are some of the things we should address first. Again, most people have a list of questions. And then the general ones. What are you hoping for? What are you most afraid of? What brings you strength? Some of the proxy questions I find very helpful. If people don't want to talk about themselves because they, again, either feel threatened or uncomfortable or just processing, ask them about what their partners might be feeling if they're not here. What would your extended family member say if they were here? What would your kids say if they heard me talk about their sibling like that? People find it easier to talk about somebody else, and through that, you might learn a ton about what is going on in the background. And then, of course, do you perceive any decisions that your team is asking you to make? I feel like we throw around the word decision constantly without actually talking about it to the family. And sometimes they have no idea what you're proposing. And again, I think it's important to just name it. I know you will have a whole other lecture on communication around care at the end of life. So it's just really a tiny venture into that. There's a lot of conversations about what a good death is. And I think when you think about palliative care, if you think it's limited to the care at the end of life, which of course it's not, you think we're there to promote a quote unquote good death. And these are some of the outcomes of successful palliative care involvement. Some I think are good and some are quite flawed for reasons we don't have to go into now. But you also know that some parents need to see a full attempt to accept an eventual death, framed by personal experiences, faith, hope, loss of trust, especially if death has been predicted in the past. So sometimes it's a code. And the question from the nurses is, why are we doing all this? And so some of the communication tools to guide the family through that, as you know, it's heading that way towards a code in a kid who you think is going to die no matter what we do, is I would focus on all the things you're doing, both now and in the future, instead of all the things that you won't do. I think we often lead with, we won't do compressions, we won't transfuse, we won't do this. But maybe start with the things that you are and will do. Offer second opinions, both internally within your unit and outside of it without applying pressure. Parents want you to see, they want to see that you're hustling, that you're really asking the right questions. It's okay to say, I don't know, but let me ask somebody else. And the language of miracles, of course. Guiding the team is critical. You need to set some reasonable limits for the code as to what you really expect is going to happen. Discuss pain control and designate a person to communicate with the family. This is, I know, a lot to cover all in 1 hour, and I want to leave some time for questions, but planned ventilation withdrawal, I think, requires a mental map so that you can go through it and then you can communicate with the family about it in a much more pragmatic way. So I ask myself these questions. Am I certain this baby will die once the ventilator is withdrawn? If not, what will keep her alive? What therapies should we continue or stop at the time of the ventilator withdrawal? Does the family want more time, or are they ready for this to be the end? Is this an extubation trial or a terminal extubation? I think this is critically important to think about together because it will guide whether you're utilizing non-invasive support and with what hopes. If the family is planning a funeral, giving you every cue that this is the end, they are certain this baby will die, and so are you, then why are we extubating to CPAP? However, if the family is using language like, we'll see what happens, I hope you're wrong, I agree to not reintubate, but let's kind of see where this goes, there is a note in there, if not more, that they want more time. So then extubating to room air may not actually be what they want. But until you ask yourself and ask the family, you might really get it wrong. How will we assess and manage some of the distressing symptoms that come up? Do I have consensus from everybody on the team that mechanical ventilation can be withdrawn? We practice in incredibly complicated environments with surgical opinions, cardiology opinions, kidney opinions. It's probably good form to talk as a team so the family hears a consistent message from all of the consulting services. And if you're talking about stopping feedings, fluids, like antibiotics, suctioning, even more critical to talk to all the team members that we're all on the same page. So once you think about that, then again, you have to think about these physiologic considerations prior to withdrawing the vent and what is contributing to the respiratory failure. And then contributing to factors in medical stability or instability, because each of these is a therapy that you're probably going to be talking to the family about, or at least guiding them about when it comes to timelines. So some of these physiologic, concepts as you're guiding the family through it, you may want to review some factors that are contributing to respiratory failure, as on the previous slide, and how they affect timelines. There's still a lot of uncertainty in that. Address whether to continue or stop other therapies. First, you have to review them. And I almost always ask in a kid who I think might breathe, what would it mean to you if he continues to breathe? And you will hear all kinds of things. You will hear people say, that means you're wrong. That means it's a miracle. Or they'll say, I know it actually doesn't mean much. I know that his future is still kind of like predetermined and that eventually he will die. But don't ever let the family be caught off guard that you pulled the breathing tube and the baby's breathing. You may want to prepare the family for some physical changes, such as changes in color, temperature. Explain how you'll monitor and manage pain, agitation, and dyspnea in all kinds of ways. Explain what terminal breathing is, that it's sporadic, there's apnea, but patient is unconscious. We say there's no need for medications, and that is true from like a physiologic perspective, but it looks so gruesome to some parents that you still may have to give a medication either for the family's comfort or for the nursing comfort. Honestly, that's probably okay. Why is it important to guide the family through possible symptoms? It's because we think we're doing a pretty good job at that, but actually some parents don't think we're doing a good job on that. And there's also evidence to suggest that parents who felt unprepared for symptoms and changes at the time of death perceive their child suffered more, which leads to just more complicated grief. Some psychological aspects of care, which I'm confident you will cover in other sessions, legacy making, bereavement, through breast milk suppression or donation, sibling involvement, spiritual care needs, photography. Always, as with previous discussions, follow cues on how much parents want to tolerate. Some people want to know a lot. And so you can ask, you can say, as we're preparing for this day, I can guide you through what to expect. I can guide you step by step what it might look like. And some parents are really with you. They want to hear. And some people say, I can't. I just cannot peek behind that curtain yet. I do not want to know. Just tell me in the moment. So again, don't always assume that people want to know what you're about to tell them. There's lots of cultural and personal preferences around holding babies, who's in the room, who's not in the room. Very, very important to connect with your spiritual care and your social work colleagues and child life colleagues as well. They usually kind of know this space, and just be patient. I often see fellows, especially when I get through this conversation in one day, like today we're going to talk about this terminal extubation, like this is my task, and you just want to do it all. Sometimes it takes 3 conversations, again, about symptoms, about who's in the room, about the logistics, people change their mind. This may take longer than you think. There's a lot of meaning in this. I'm a big fan of just like protocols, because it would help you then focus on the meaning and not on the check boxes that you don't have in your mind. There's unit champions. I think there's a lot of value that needs to be stated of this care despite the death, especially in chronic kids. There's often the sense of not just loss of the baby, but loss of time and resources and investment. And that's really hard to talk about. But again, it's usually a highly, like valuable process for the family. There's lots to learn from parents who've been through this. These are just some papers to point you in that direction. But again, there's a ton of literature in there on how to partner with parents who have lost children in the NICU, in the cardiac ICU, in the PICU, who will teach us better. And I will leave you with this. Despite training, practicing, and really being fantastic in communication, there will be days when it's all a haze. It's just a mirage. It didn't really happen. But I really hope that with concrete tools at your disposal, it will be less daunting, less fuzzy, and just overall better for both you and your families. So I thank you for your time, and I hope we have some time for questions.
We definitely do have time for some questions. Thank you so much, Dr. Henner. That was a very thought provoking and a very informative session. We sincerely thank you for your participation and reviewing some of the basics of communication with palliative care in our NICUs. We did have some questions in advance that came up. If you do have questions after this talk, feel free to type into the Q&A uh, uh, section in this chat. We are constantly monitoring them. But one of the questions that did come up, and this is, I think, a common question also, is that what are some of the phrases to absolutely avoid in having a conversation, palliative care conversation in the NICU?
I think I mentioned a few, but there's nothing we can do. Seems like top of the list. There's always something you can do. You just have to reframe what it is you're doing. There's nothing to hope for. There's usually something different to hope for. Being very sort of clear about the facts, when in fact the facts are maybe feelings about the facts. I don't know that that's a phrase, but again, being too like over definitive about the future in general is our biggest pitfall. Yes, there is a kid who is on high frequency ventilation, 100% oxygen, saturating 80 on nitric and 3 pressors, that you're talking about stopping mechanical ventilation. There is absolute certainty that that baby will die. Of course, and we should prepare the family for what it looks like. But there is a baby with severe HIE who you don't know if they actually swallow because they have a breathing tube, who don't look like they're breathing on the vent. You kind of have to wonder, what if they do? And we still say this baby's going to die, and that sets up all kinds of problems in the future. And so if you have doubts, and you only will have them if you think about them, right? If you always think that you're right, then I guess you don't have any doubts. But I think communicating those doubts to family is the right thing to do. It doesn't mean you were wrong. It means you actually thought about it.
Mhm. Yeah, that's a very fantastic point, and definitive information. I know we want to give, and I know we are a community which goes on, believes in definitive communication skills, but this is a different topic. The second question that did come up was, do you think there is room for non-traditional methods or other innovative methods of teaching communication in curriculum? I know you teach communication in fellowship, but are there any non-traditional ways of doing so?
So, I mean, like simulation training, I don't know that it's non-traditional. I think it's becoming a lot more normative. We are very big fans of that. I don't know if the fellows are or not. It's always hard, but I think most of them walk away thinking this was a productive use of their time. But we're actually exploring ideas of this sort of 360-degree sim where a physician pretends that they're a nurse and a nurse is a physician and a hospitalist is a social worker. Because I think there's a lot of sometimes tension between our nursing colleagues and physicians where the nurses say, well, why didn't you just say it? Why didn't you just tell them X, Y, and Z? And I think it's important to be the one to practice saying that. And it's important for the docs to be in the background and be like, oh, it's really hard to not talk when I have a certain feeling or when I've seen 50 kids with this condition. But as a nurse, sometimes you're not the one guiding these conversations. And so I wonder if in the future there's this more sort of like role changing simulations. It's a lot of resources, a lot of time, but I wonder if that's something. And then another thing we are doing at Lurie, I know we didn't have a lot of time to do it this year, but just shorter sims. I think people think of communication simulation as this multi-day, like production, which is what we do, or it's a half a day, it's SPs, it's a lot of resources and time, but just really short scenarios, 20 minutes, just a faculty who's good at this, who the fellows trust. You pull somebody from service. It's just like putting in a chest tube, right? You run a communication sim as part of your unit, whether it's once a month for each fellow, maybe it's a couple of times a month, but it's not expensive. You don't need standardized patients. And it's about maybe even the stuff that's currently happening in the unit, right? You know that there's a baby with significant bleeds or with a new stroke post ECMO. Like you can practice just delivering those news or processing those emotions. It feels very much in the moment. Again, it's just a little bit simpler to do.
Yeah. Yeah, on that nursing involvement and nursing emphasis on that, there is a comment here that I'm going to read. I think it is important to make sure that nurse is on the same page with the discussion the NEO team is going to have with the families. Maybe this means briefing them after talking with the families or including them in the discussion about where the family currently is. Nursing sometimes has built a rapport and is with the family for upwards of 12 hours a shift and can be key in understanding and getting a feel for what families want for their child.
I could not agree more. I think including nursing in every family meeting, in night huddles, especially for nighttime nurses, where you talk about the daytime meeting and you summarize it, writing much better notes in the chart than we currently do about summarizing these discussions so the nighttime shift can read them. I think there is a lot of gaps and flaws in the current system and how we partner with our nursing teams, again, especially when it comes to shift work. But it's critical that they're there, and it's critical that we ask them before the meeting. So part of that meeting prep, again, in an ideal scenario and you have time, is you do a pre-meeting. And that involves a bedside nurse, a social worker, a chaplain. Again, all these people have a relationship usually, a psychologist, a trainee who might be struggling with this a lot, but don't have a space to say that they're struggling, where you talk about your plans for this meeting. What do you hope to achieve? You solicit all this input from people who know the family about, well, how do you think this will go if I say this? Again, not to say that you shouldn't try it, but you would at least know what you're walking into. I think that prep is often, I don't know, 30 minutes to an hour. In our busy units, it's hard to take that time, but maybe if you take 10 minutes and include a nurse, that's fantastic. It's even more critical when you have lots of disciplines: cardiology, surgery, ENT, neuro. Everyone just walks into the room and starts talking. And again, I think you need a good 20-minute prep to again understand, like, are we asking this couple, this family to make a decision about something today? Are we just disclosing our collective worries? Like what is kind of like the highlight of this meeting so that we can all be on the same page? And if you all agree that the highlight is purely to disclose difficult news, then your surgeon shouldn't start talking about a G-tube until the family is guiding all of us that we're ready to do that.
Mhm. Yeah, I absolutely agree that pre-brief and debrief are both
Mhm.
very important and critical aspects in situations like this. One additional question came in is that what is the role of a social worker in palliative care cases? This could potentially be addressed in another future session that we have upcoming, but wanted to get your opinion and thoughts on this.
I mean, I think it's critical if you have social workers in your unit who know families. There are some palliative care teams that have a dedicated social workers. Again, I didn't focus this talk on just palliative care service because, again, I think these are all primary palliative care skills that the neonatologist should deploy. And so I think social workers, at least in my experience, have great insight to the family. They also understand what are like the day-to-day hurdles that this family is facing: travel distance, other kids. Like, as you're proposing these decisions and plans, I think they should speak up and say, as we're considering chronic mechanical ventilation, let's acknowledge or let's think about where this family lives. It just may not even be on your radar. I also think they're a good conduit, a great conduit between the family and the medical team, because if the family's quiet or they're too mad, a social worker can ask a question on their behalf because they know them. And maybe the family has asked them to ask a question on their behalf. And so again, I think of them as a key sort of team member, but it takes time. It takes time and resources.
Could not agree more. Thank you so much. I think these are some of the main questions that we had. We may have time for one more question, but while people are typing that up, I will foreshadow in our next webinar, which is our palliative care in the NICU and beyond. How does ethics fit in? It will be led by Dr. Brian Carter. It will be on April 8th at 3 p.m. Eastern Standard Time, and registration QR code is right there. There are three additional QR codes in this slide. First one is to evaluate our webinar and speaker. We can always learn from you and give whatever our participants need and want. You can also register for Ethos and claim our CME in the second QR code. And there are some questions for MOC Part 2 credit in the third QR code in the slide. Thank you so much, Dr. Henner. It was a pleasure to hear from you, learn from you, and thank you, everyone, for joining us.
Thank you again for inviting me.
Thank you.
Bye.
Gretel, I'm so sorry. I just saw your email, your message. I'm so
That's okay.
sorry.